Hello, my name is Nathaniel Osgood at the University of Saskatchewan. It's my great pleasure and honor to be here today to share with you some work that I'm conducting with my colleague Dr. Roland Dick at the Saskatoon Health Region and the university. Looking at the ways in which large disparities associated with diabetes within our province may in fact lie in their origin in a very vulnerable period of life. The broader context of this work lies in a program of research that seeks to understand a troubling and deeply rooted series of syndemics that currently afflict our Aboriginal population within the province, population known as First Nations or Indigenous people. While this work focuses on a linkage between type 2 diabetes, gestational diabetes, and obesity, it's part of a broader milieu of research that seeks to understand multiple of these linkages so that when we assess, among other things, the impact of an intervention and seek to understand its health and cost implications, we can do so with a much broader lens, a lens that allows us to understand the effect on multiple conditions, the ripple through effect how one condition affects another. The historical context of this work lies back 20 to 25 years ago. My colleague, Dr. Dick, was a practicing transplant nephrologist in Saskatoon and noted a troubling trend with a large increase in the number of Aboriginal women that he was seeing developing end-stage renal disease. And this embarked him in a program of research that continues to this day, much of it having been conducted in the past decade involving me, which studies a variety of these interacting factors. We see here one of the most important sets of findings that came out of this work as part of a 25-year study of administrative data we have in Saskatchewan, being the birthplace of Medicare. We have this hemisphere's richest set of data, administrative data for health purposes. And we see that from this administrative data, using a validated algorithm, a troubling trend associated with diabetes. Three large factors should be evident when you look at this graph, which shows on the x-axis the year, and the y-axis the standardized diabetes prevalence rates, age standardized. Number one, we see an overall rise in rate, a rate that goes up almost by a factor of 3 in some of the groups over the period of 25 years. Secondly, over all the years, the Aboriginal people are subject to quite a lot higher rates of diabetes than our non-Aboriginal individuals. Thirdly, while the non-Aboriginal population exhibits a pattern seen widely within the U.S. as a whole, which is rates of diabetes among men outstripping those among women, among our First Nations population, it's quite the reverse, with women being associated with higher rates than men. Now these differences, these disparities extend to other factors as well. We saw prevalence. What I'm looking at now is incidence, with the x-axis indicating the year of diagnosis of diabetes, and the y-axis case numbers, the different bars showing different periods of time. What this graph shows is that among non-First Nations females, diabetes is, particularly type 2 diabetes, where the rate's been rising rapidly, is predominantly a disease of the older years, of the final decades in life, with most cases occurring in the oldest decades. By contrast, among First Nations females, we see something very, very different. We see rates of diabetes that historically peak in terms of incident cases within the middle decades in life, and with a notable number of cases occurring in the reproductive years, 20s and 30s. These trends helped alert Roland to the importance of a variety of other factors, particularly in some early work done in conjunction with our tuberculosis control program, with whom we work very closely as well. He found that within more remote communities, prior to the emergence of the type 2 diabetes epidemic, there was a striking rise in rates of obesity, the rates of gestational diabetes. Gestational diabetes, for those not familiar with it, is a type of diabetes that first manifests during pregnancy, and on a province-wide level, approximately 3 to 4% of pregnancies give rise to gestational diabetes. However, this figure is several times higher in the teens for our Aboriginal population. And what's notable is that this gestational diabetes is important as a risk factor, in addition to being a nuisance and decreasing quality of life during pregnancy. It's a potent risk factor for the mother, increasing the risk of being associated with much higher risk of subsequent gestational diabetes, but also type 2 diabetes, with almost 5 to 10% of women going on to develop type 2 diabetes shortly after pregnancy, and those who avoid that just after pregnancy, with 2 to 5% per year going on to develop type 2 diabetes. What's particularly troubling is that it's also a big risk factor for the offspring, conferring high risk of macrosomia, an important contributor to birth complications like dislocated shoulder, high rates of childhood obesity, and risks of type 2 diabetes and gestational diabetes, it appears, later in life. These relationships are it's clear, in many ways, they include substantial causal components. For example, we see dose-response relationships related to level of glycemic control exerted during pregnancy on the one hand, and diabetes in offspring on the other. We also see pronounced differences in the outcomes for siblings within the same family that were exposed to a diabetic uterine milieu, and those who were not exposed to such a diabetic uterine environment. So I've noted a variety of connections here that have been commented on in the literature, and the evidence for these connections are very strong. What we've tried to do within our modeling is to complete the circle, as it were, to put the pieces together and to understand the ways in which they may be contributing to two vicious cycles, ways in which high rates of gestational diabetes during pregnancy may lead to further enhancement of those risks, and to further risk of type 2 diabetes in the woman, which yet increases the amount of diabetic pregnancies. But further in the child, how diabetic pregnancies in one generation predispose the next generation, even beyond the rates of the previous generation, to diabetic pregnancies and to type 2 diabetes. Despite these linkages being fairly well documented in isolation, estimating the contribution of gestational diabetes to type 2 diabetes, understanding the attribution, is difficult. It's extended through diverse pathways. There's long time delays associated with it, which make it difficult to run large-scale longitudinal studies. And it's affected by a variety of mediators, including fertility rates, the age of the mother at time of giving birth, and dynamics associated with risk factors that change in parallel, such as weight trajectories. So in order to tease out the contributions of gestational diabetes historically to type 2 diabetes, and then to use that information so that we could look forward, prioritize data collection, and try to understand trade-offs between interventions, we turn to complex systems modeling, a type of modeling that I've been doing now for between 20 and 25 years. And in the process, we've evolved quite a number of different models. I'm going to focus on one of them here, give a glimpse of the second one, but bear in mind they're part of a suite of models. Model I've comment on most extensively is a system dynamics model, a model which depicts the population as divided into a set of health categories, shown here as in rectangles and stocks. They're in some sense accumulations of people, each of which counts the number of people that they're associated with a certain health state, and therefore lie within that, are depicted as lying within that category. And individuals over time flow between the categories. So, for example, we have individuals who may initially start with a normal weight and then over time develop overweight. Or individuals of either weight status may develop type 2 diabetes by flowing along these paths here. For women, there's additional stalks into which they can enter. Stalks associated with pregnancy, weight change during pregnancy, associated with this flow, and there's a risk that they may develop gestational diabetes. Having developed gestational diabetes, the model then remembers them as associated with a history of gestational diabetes if they haven't already gone on to type 2 diabetes. This history predisposes higher risk for subsequent type 2 diabetes as well as recurrent bouts of gestational diabetes. Women, when they come to term following the pregnancy, they also give birth to offspring which are born into the model, which are tracked in a way that the model remembers whether they were exposed in utero to diabetes. The model incorporates not only births but also deaths, migration, and reflects reclassifications associated with individual ethnicity, etc. While it's not obvious from that diagram, the model is actually quite a bit more detailed than might be obvious. It's stratified into 5-year age categories. It distinguishes, of course, by sex, but also by ethnicity and in utero exposure, further by weight, as we've seen. And there's a time horizon of approximately 50 years, and it steps out in 3-month increments. In building a model like this, to secure quantitative insight, it's important to describe not only the equations that describe the flows among various categories, but to describe associated estimates for various model parameters. The parameters for this model were estimated in 2 different ways. One was direct estimation, which made use of not only primary data to which we had access within our research group, collected predominantly by Roland Dick and collaborators, but also survey data, Saskatchewan health administrative databases, and a very rich secondary literature. Literature that allowed us to collect information on demographics, pregnancy-related risks, type 2 diabetes risks, etc. But a second source of model parameter estimates was calibration against a variety of cross-sectional time series. For parameters which we couldn't estimate directly, we associated them with values that seemed to confer the best fit to the data that we could observe on a wide variety of factors in the model, related to dozens of time series. So we simultaneously calibrated this model against dozens of time series involving a wide variety of factors, and we held the model to a high standard to account by further doing what's called cross-validation, checking the results of the model to predict things that we didn't directly tell it about. Now, this calibration process was a long and involved one, and actually led to very important discoveries about the model that led to very significant model refinements, to extensions to the model, enrichments, and to identification of key uncertainties, as we'll talk about. This is an example of a refinement, or of a match associated with the model, where the red is associated with historic data. Where it's flat, there's no data available. Now, some overall findings from this model. The first finding is that gestational diabetes is likely contributing very heavily to growth in type 2 diabetes within Saskatchewan. This is a sobering finding. It says that this vicious cycle that we see could be having very significant adverse impacts within a province, adverse impacts that could end up costing very, very disturbing sums of money, but more importantly, having a terrible human cost, both in terms of quality of life and length of life. Troublingly, these effects are much larger. You see much larger among First Nations peoples, where appears that anything from a quarter to nearly half of all type 2 diabetes might plausibly be attributed to gestational diabetes. And these effects of gestational diabetes on type 2 diabetes, which have been seeded over the past several generations, are growing. Secondly, glycemic control in women of childbearing age has a disproportionate impact on future health and health of future generations. Not just the health of the mother later in life, very important though that is, but of future generations. Now, to give just a little bit of the flavor of how we might go about examining these things with the model, when we have a model like this, we can run a baseline run, shown here in blue, and then we can compare the outcomes from that baseline to a variety of what-if scenarios that ask counterfactual questions, seek to understand how the situation would be different in different situations. And in this case, for the red line, we've turned off intergenerational effect associated with gestational diabetes. In the green line, we've turned off all the effects associated with gestational diabetes. We pretend essentially that that isn't having an effect in predisposing anyone, mother or child, to a risk of type 2 diabetes. Now, within the non-First Nations population within Saskatchewan, we could see that in a very, very conservative interpretation of the data, which is what I'm going to be showing you here, gestational diabetes, intergenerational, confers very, very immeasurable but small effects. But at an intragenerational level, affecting the woman, reducing the green line from the blue line, we see a much larger effect. Within this graph, which is for the First Nations population of Saskatchewan, we see that these effects not only also present, but are much more pronounced. So we see that the presence of gestational diabetes at an intergenerational level confers is associated with a significant increase in the amount of risk of type 2 diabetes from blue to red. But we also see the intragenerational effect is even larger, although the intergenerational effect is growing very rapidly. Those are very, very conservative estimates. The less conservative estimates show a much larger gap. A key uncertainty here that emerged in the calibration process, sensitivity analysis associated with it, is the rate of type 2 diabetes amongst gestational diabetes survivors. That is, among women who have gone through a bout of gestational diabetes, what's their likelihood on a per-year basis of developing type 2 diabetes? We have estimates from the literature for larger scale populations for Canada, but they don't take into account certain considerations that seem to bear particularly adversely on our Aboriginal population. And our understanding of this parameter has a disproportionate impact on the outcomes of the model going forward and and in terms of intervention gain. Now, having identified this uncertainty using this model, it helped us to mobilize us to put a lot of effort into finding information that would shed light on this particular factor. So it helped us marshal our efforts, helped us prioritize our data collection, and in this case, marshal between $10,000 and $15,000 to secure an additional data set involving administrative data that can help us estimate these particular parameters for our population in a way that could shed a lot of light on this. Very, very important contribution, and we're expecting delivery of that data set within the next 6 months. More broadly, what this work has suggested is the diabetes crisis is indeed a big danger, and there's very sobering implications. This vicious cycle associated with just linking up gestational diabetes on the one hand and type 2 diabetes on the other could mean that a given occurrence of gestational diabetes can cast shadows for generations. And what we're seeing now is a very rapid ramping up of the impact of missed opportunities in the past few generations with respect to gestational care, particularly in our Aboriginal population, as it increases rates of type 2 diabetes. However, from another perspective, what this sheds light on is a giant opportunity. Gestational diabetes is not only important, as suggested by this study, but it's also a place we can really make a difference. It's prevalent, it is preventable, it is readily identifiable, and it is treatable when it is detected. Moreover, during pregnancy, women are often in contact with the healthcare system and are motivated to take on healthier habits. And successfully leveraging this higher level of motivation can have gains that reverberate for generations. And there's lots of opportunities here for progress. And a set of these opportunities I've listed here, which put together with colleague Roland Dick, we see a variety of interventions associated with everything from those that confer benefit predominantly for the women in terms of pre-pregnancy enhanced glycemic control, lifestyle modifications focused on the woman, to those focusing on both individuals, so with breastfeeding, for example. Early screening has a large component here, both pre-pregnancy and during pregnancy effects. There's also, I should note, certain pharmaceuticals that can be used during pregnancy to help stabilize blood glucose levels. Now, in order to understand the impact of these interventions, particularly the more complex interventions that may be targeting particular subgroups in different ways based on someone's history of gestational diabetes, for example, or interventions linking mother and child, we've been turning to a different sort of complex systems modeling. Been turning to agent-based modeling, which depicts individuals at an individual level and follows them out in their trajectories. So here we're characterizing the synthetic population at an individual level, not just counting the number of people who are in a given category at a given time. We're following individuals through their life course, and we can represent nested and networked relationships between people, such as within a family. And such an agent-based model permits representation, rich representation of factors like intra and intergenerational family context, important risk factors such as rural-urban distinctions, an individual's current weight or glycemic status, diet and physical activity level. It can capture individual trajectories and histories over time in a way that might be targeted by intervention or used to match up historic data. And it can allow us to further capture, in the direction we're going, blood glucose dynamics. Now, the capacity to represent such elements permits a variety of things. Higher fidelity representation of relevant dynamics. We can more detail describe, for example, the life course effects of early life insults in the form of diabetic exposure to diabetic milieu. It permits calibration and cross-validation of the model against longitudinal data in a way that just isn't possible with aggregate models. It permits investigation of interventions that are finely targeted and are more complex, based on individual histories, based on seeking to build, say, social capital or strengthen networks. So we have an agent-based model, which is been being built up incrementally, as is advised, with many pieces of it already in progress. I'm going to have to finish up here in just a moment, so suffice it to say that we have quite a set of ongoing and future work. It includes completion of the model, incorporation of this rich new data that will be arriving soon, which we've requested because of the high sensitivity in the earlier model. And a model that, in using the newer model, conducting a set of intervention analyses that will allow for understanding of very, very concrete intervention strategies that speak to clinical understanding. We're going to be also combining it with a set of other models that capture diabetes complications, end-stage renal disease, for example, cost components. Very critically, we're going to be linking it in with data from our smartphone-based system, iEpi, which we use to collect very fine-grained, multi-minute level data that can include things such as individuals' weight trajectories, individuals' physical activity levels over time, their eating habits, and aspects of blood glucose dynamics. Just in some closing thoughts, being that we're in a complex systems approaches, simulation models can really help aid understanding health disparities. They can help understand the consequences for health disparity of early experiences on later life and on future generations. They can help us describe, evaluate, and understand implications of best guesses as to how things work out there, and let us investigate different hypotheses. They can help complement and leverage data, clinical knowledge, and shed light on how interactions of diverse factors lead to the observed patterns. They can prioritize data collection, as they have here, and interpret trends. And they can lend insight into intervention trade-offs and aid in planning complex and multifactorial interventions. I'd like to provide my sincere acknowledgments to my co-investigator, Dr. Dick. It's really the inspiration for so much of this work. Co-investigator Linkages Grasman, who helped out with some aspects of the gestational diabetes model as well. To funding from NSERC and Saskatchewan Health Research Foundation, the USTEP program within the university, Mary Rose Dang, and students Jing Bai and Amy Gao, who's currently completing the larger end-stage renal disease model for diabetes. Thank you very much, and I'd welcome any questions.